Okay. No, we're a little on a time crunch, so I'm gonna get started. Let me share my screen. Yep. And then- okay. Can see um everyone see my presentation? Cool. Let me add in some last minute people that are waiting. Okay. Just a note up at the top. This presentation is going to be recorded. We will be sending that out later on. Just so for everyone's awareness, this presentation will be recorded and we will be sending it out at a later time. Let me start recording now. Oh, we've already started recording. Okay, great. So welcome everyone. My name is Josh Schenkel. I am a program manager here at CRISP. I work on the Office of Advanced Primary Care Programs here at CRISP. Um, and today we're going to be talking about the Medicaid Advanced Primary Care Program, specifically the multi-payer uh, reporting suite aspect of it. Okay. Little agenda over. We're going to overview the multi-payer reporting suite. We're going to talk about the Medicaid Advanced Primary Care Program and multi-payer and how those two interact and how multi-payer can be useful for the Medicaid Advanced Primary Care Program. And then our friends from H Metrics are going to do a live demonstration of the multi-payer reporting suite. Here's a little overview. CRISP, in partnership with H-Metrics, created the multi-payer reporting suite to support alignment between Maryland Medicaid and the Maryland Primary Care Program. The suite of reports helps users understand trends in hospital utilization, facilitate care coordination, and monitor population health across their Medicare and Medicaid beneficiaries. Um, CRS users with assigned patient panels are able to use multi-payer. This includes physician practices under MDPCP, PC Ahead, Medicaid Advanced Primary Care Program, and also non-MDPCP panel organizations. Also, MCO users are able to use multi-payer, as well as hospital users and other CRIS participants that submit clinical panels, including care coordination groups. The multi-payer reporting suite data sources. The suite displays the following data for patients on the organization's panel. This includes the Medicare fee-for-service patients, the Medicaid fee-for-service patients, and the Medicaid managed care patients. And the data also includes all care settings and services covered under Medicare and Medicaid. Data displayed in the report are for the last 36 months, and there's typically around a 2 month data lag in the report. Here's a little bit of a Venn diagram that helps explain what is able to be viewed within the multi-payer reporting suite. So it is a combination of your organization's panel as well as a Medicaid fee-for-service or Medicare fee-for-service or managed care participant. So those are the type of patients you will see on your multi-payer reporting suite panel. It will not include patients that are not either in Medicare or Medicaid, or they are not in your panel. I also note as we're going through this, if anyone has any questions, please put them in the chat and we can review. But yeah. Here's a little background on the Medicaid Advanced Primary Care Program and multi-payer. So the Medicaid Advanced Primary Care Program participating organizations are able to download their managed care organization assignment lists using the CRISP reporting services portal. If you do not see or have access to that assignment list, please reach out to your CRISP outreach representative and they can make sure you get set up. Organizations can also use these lists to complete patient outreach and also upload them in a CRISP SIN panel to view their patient's health data. I will mention with the CRISP SIN panel, please make sure you are communicating with your CRISP outreach representative because for the MCO assignment lists, you will need to have a Medicaid specific panel that you'll need to upload since the identifiers for that population is going to be using that Medicaid ID instead of your typical medical record numbers at your organizations. Um, and then the Medicaid Advanced Primary Care Program, organizations can view claims data for their Medicaid enrollees using the multi-payer reporting suite. Okay. Here's a little bit of a screenshot about how to download your MCO assignment lists. It's available within the CRS portal. As I mentioned, if you do not see it, please reach out to your CRISP outreach representative to get you access. Um, the list can be submitted to CRISP via a panel available or via a panel that you would submit via Send in the panel processor tool, and then that would panel would then generate in the multi-payer reporting suite. I also mentioned we had a CRISP open office hours in late January where we covered this process in more detail. And so we have the recording for that session available here. And so you'll have it when we send out the slides. And with that, I think I'm going to pass it over to Audrey Speeder from H Metrics.
Great. Thanks, Josh. I'm going to take, oops. Josh, if you can stop sharing, I should be able to start sharing.
I've stopped sharing.
All right. It should be up any second. Can you confirm?
Yep.
Perfect. Okay, welcome everybody. Thank you so much for taking the time today to talk with us about the multi-payer reporting suite. The perspective I'm going to be giving you today is I believe most, if not all of you, should be participating in the Medicaid Path Primary Care Program. Many of you being in cohort two. Cohort two starts of January 1st. So we wanted to make sure that everybody has the perspective they need in order to use the multi-payer reporting suite effectively. So as Josh outlined for you, before you can even get into this reporting suite, you're going to need to download your MCO assignment lists. You can then use those for your personal outreach or do other stuff in-house. But it's really important that you take those assignment lists, you submit them through Send to create a Send panel. And then once all of the provisioning is done through your point of contacts at CRS, you're going to be able to access that, that panel in multi-payer reporting suite. So all of those are kind of the precursors of what needs to happen. But once you get that all taken care of, I'm sure your outreach representatives at CRISP will definitely help you get to that point. I'm going to take you the rest of the way to make sure that you're understanding how to use the reports. So we'll use about the next 50 minutes. I may go a clip fast. There is a lot to cover here. So if there's any questions, definitely reach out or we can follow up offline for anything we don't have time for. All right. So when you enter the multi-payer reporting suite, the first thing you're going to see on the top, on the very top is going to be your global filters. If you are a user of the multi-payer reporting suite for more than just your Medicaid Path assignment, you may have other panels to select from on here. For the purpose of our conversation today, I'm using my demo panel of TIN 001. This is a complete demo panel. Nothing you see here is PHI. Everything is masked for patient safety. Some of the trends may look a little wonky, but that's what you get with demo data. So just disclaimer, there's no PHI on your screen at any point in this presentation. So in addition to selecting your panel, if you have more than one, you also have an opportunity here to select a roster, and I'm going to walk you through that functionality momentarily. And you also have the opportunity to isolate a single payer. So as Josh introduced, multi-payer reporting suite is the first and currently only reporting suite in CRS that has both Medicare and Medicaid claims together at the same time. While the focus of our conversation today is going to be your Medicaid population, if you choose to use multi-payer for a broader purpose, or if any of you are co-participating in MD-PCP or PC Ahead. Um, you can have Medicare panels or combined panels, and you'd be able to isolate only the Medicare or Medicaid or both using this filter. There's a little I button here, and this just gives you a quick look of what is being shown in your population. So for my panel today, I have 2,000 beneficiaries, all of which are Medicaid members. 309 happen to be dual eligible. They also have Medicare. So just keep an eye on this. It'll also let you know if anybody is not being visible, if you happen to be uploading patients with commercial insurance or anything else. But again, if you stick with your MCO assignment list that you download from CRS, this should be very straightforward and you won't have any patients dropping out. All right, starting with the population summary screen, this is what we consider our dashboard. This is a high-level view of all the reports in the reporting suite and a key metric for each of them. It is conditionally formatted, so hues in green indicate that you have measure performance that is more favorable than your comparison group. And in this situation, this will be the state overall's performance rates. Anything in red is going to be less favorable. So you'll see here that my made up panel here has really favorable PQI rates, favorable readmission rates, and favorable inpatient admissions, and doing not so great in my ER visits. So this is also effectively a table of contents. All of these widgets here are interactive. So if you click on any of these, it will take you to one of our reports. You can also access that from the left menu. All right, so to get started here, I know here I have 2,000 patients. I have my widget here that confirms I have 2,000 patients and I can navigate directly to Population Navigator. I'm just going to do it from the left menu. It'll get me to the same place. And Population Navigator is going to be kind of your home page if you want to start getting into the who of your population. Who are the patients or the members represented in your panel? What are their high-level clinical and demographic characteristics? And it gives you the opportunity to create rosters. Rosters are effectively your personalized, customized list that is a subpopulation of your panel. So if you are using your MCO assignment list and you turn that into a panel, your MCO assignment list is at the level of your participating TIN. It varies for all participants, but some TINs have multiple different practices or different locations. Some TINs have numerous different primary care physicians participating in the program, just depending how small or large your entity is. All of those patients are going to be loaded into your panel, but you have the opportunity to filter that down to a population that's more meaningful for you. So for example, if you are on the ground at an individual practice within your participating TIN, you can scroll over to these columns here and you'll have a practice name, you'll have an assigned PCP, you also have the assigned PCP NPI, and you have your affiliated TIN. Everybody should be within the TIN that you just uploaded your panel for. And the Population Navigator functionality gives you the opportunity to filter that down to what you're looking for. So I'm going to walk through a scenario of, let's say I am interested only in a filter for Dr. Dittmer. If you go ahead and type that into a filter, you know that I started with 2,000 beneficiaries. I am now going to be filtering my population down to, oops, that didn't reset, to less than 2,000 beneficiaries. It also gives me the opportunity here to do additional filtering if I want to then be able to say, I'm only interested in the people, there you go, it updated for me to 828 members that have a primary care physician of Dr. Dittmer. If I want to go even further and I want to understand more about a distinct patient population based on chronic condition, you have a measure bar. It's a collapsible measure bar on the right. This is giving you the opportunity to isolate members who have distinct chronic conditions as defined by the chronic condition warehouse algorithms. And these will be reflecting members who have those conditions anytime in the last 3 years. So if I were interested in a population for those that have, I'm going to say diabetes and hypertension, because that's of particular interest to me in my practice, I'll know that I have 104 members that have diabetes. I have 193 members that have hypertension, but if I go ahead and select both, it is going to give me the population that has both diabetes and hypertension present. So first I'm applying my depression. Oops, I got depression in there. Um, we can adjust that. I want to go for diabetes. And then I want to go for hypertension, and this is going to isolate my population. It's going to give me about 80 members at the end of the day. And if this is a population that is of interest to me, let's try that one more time. If this is a population that is of interest to me, I'm able to save this population, create what's called a roster, and apply this specific list of 80 members to all of my other reports. So while you're making it in the Population Navigator view, once you save it, I can look at any of my reports on the left side and be able to say, I only want to see the results for the members who have a primary care physician of Dr. Dittmer that have both diabetes and hypertension as their chronic conditions. You can use any of the columns in this view to filter as well. So I can even isolate by age, by gender, um, by county if I'm interested in it geographically, or if I'm looking for people that only have high inpatient utilization. All of these are filterable and fully customizable. So let's say I want to stop here with my 80 members. If I go up to the roster button and click create, I'm given the opportunity to create a roster. I'm going to say Dittmer, diabetes, and hypertension. And I'm able to make that off of my current view. If there are others in my office who I think would like to have access to the same roster, you can go ahead and make it public. If not, that roster is going to be limited to only you. And when you go ahead and click create, it's going to give you a walkthrough to just say, are you sure? Do you have everybody you want to include? Is there anything you'd like to change? So it's just telling me I'm going to make a roster with 80 members. These are all the members. I can include or exclude anybody if I need to. I'm just going to go ahead and accept. So now you'll see at the top of my screen, I now have a roster for Dittmer, diabetes, and hypertension. And that roster is going to persist throughout the rest of my reports. I am going to take that roster off in just a second to make sure we have enough volume to show you some more meaningful trends. I'm just going to give this a second to restart. And we are, all right, we're ready to now move on. So once you have a roster, or even if you don't want to have a roster, you can go ahead and jump into your first report, which is the measure comparison by trend report. This is a high-level report that effectively takes all of the reports on your left menu and shows them to you in one screen. So we are looking at utilization trends for the most recent month relative to 12 months prior. So this is a year-over-year comparison where you can see how inpatient admissions, ED, non-emergency ED, readmissions, and PQI and follow-up rate have changed over time. It's looking at your population on the left side compared to a comparison on the right. You have an opportunity to always change your comparison group to look at the Medicaid population. The Medicaid population is the state Maryland Medicaid population, both fee-for-service and encounters, fee-for-service and MCOs. So it is not a program-specific comparison. It's not letting you know your population compared to all Medicaid Path members. It's going to give you your the overall state comparison. So just be mindful of that. So like I said, this is just a high level view where you can see trends. You can look at seasonality. You can also look to see if there's any correlation between your results or between your performance. So are there spikes in, when there's spikes in inpatient, do you also have spikes in readmission? You'll be able to see some trends that way. And if you want to understand more about them, your next step would be to get into the actual reports to see those details yourself. Okay. Jumping now into acute care setting. While that's loading, I am seeing a few questions come through. I'm going to maybe pause after a few of these and we can revisit that. I can't keep an eye on both. Josh, if you see anything that warrants immediately pausing and jumping in, definitely don't
Yep.
hesitate to interrupt. I don't
Yep.
want to lose people along the way. Okay. The first reporting suite is, or excuse me, the first report is the acute care setting report. This is focusing on your total inpatient admissions and readmissions. This report is structured a little bit differently than the rest. This top panel here is going to be your population. So right now I'm looking at my roster and I'm looking within my panel. So I'm looking at the monthly trend of inpatient admissions and readmissions and comparing that to the dollars for those inpatient admissions and readmissions. And right below that, you have the comparable information for your comparison. Again, this showing Medicare, you can flip it over to Medicaid. So it's showing you your trends over time. I'm actually going to remove my roster just so I can get some more volume here and smooth out some of my trends. I don't want that to be distracting. There you go. That's better. So this is showing you your trends over time. You see your hospitalization line compared to your readmissions and your dollars for hospitalizations and readmissions. And as you scroll towards the bottom of the page, we are looking at the prevalence of those admissions by whether that hospitalization or readmission was avoidable or not using a PQI definition. This is by hospital. You can also do it by the primary diagnosis of the admission or readmission. And we provide some additional details if you want to look briefly at utilization by patient or utilization by hospital. Everything here is interactive, as is all the reports. So I'll show you this functionality one or two times, but I'd like you to be aware that you can apply it anywhere. If I'm interested in highlighting only the population, let's say I want to choose sepsis, I have 22 inpatient admissions for sepsis in my population. If I go ahead and click on this line, everything is going to update to show me the details of those 22 sepsis admissions. So you'll see that I now have much fewer bars here. I'm only highlighting the distribution by hospital for sepsis admissions. I'm only seeing the patient details. Oops, I clicked off. I'm only showing those details for patients with sepsis, and I'm looking at the details of those admissions. This cross-filtering, like I said, applies everywhere across the report, so please feel free to use it. We also have the opportunity here to look at beneficiary details. So if I'm interested in understanding who are those patients, tell me more about them, and you want more than just that quick table at the bottom. If you hover over your bar, you'll see a beneficiary detail pop up. You also see claim details. Claim details is going to give you the details about those 22 admissions only. Whereas the beneficiary details are going to take me back to Population Navigator, and it's going to allow me to see more details about those 22, well, the beneficiaries with those 22 admissions. Something to keep in mind. Oh, yeah,
Audrey, I think we got a good question in the chat that I just wanted to bring up.
cool.
Basically, the question is about the follow-up status on the beneficiaries and like how is that reflected through the claims data and what's typically like a lag you would expect that there has been follow-up um,
I'm not sure I'm following. You don't mean from the follow-up discharge report. You mean from an
from
actual
the
Population Navigator
population
value?
explorer.
I think you're thinking,
Uh,
okay.
okay, maybe they're
Um,
talking about. Sorry, I might be confusing it. I think they might be
Population
talking
Explorer.
about.
Yeah.
Yeah.
We don't have
Okay.
follow-up tracked in
Yeah.
Population Navigator. This is only claim-based measure, only claim-based details. Um, yeah, if we can take some time at the end if we want to differentiate Explorer from Navigator. Names are similar. Um, okay. So I was saying before, just because you have a number of admissions doesn't mean you have that exact number of patients. My demo data got a little wonky. I have more patients than admissions, which is unlikely, but you'll often see that if you have maybe 20 admissions, you might only have 10 patients representing that because some patients can have more than one admission with the same diagnosis. So one functionality I did not cover before is if I'm looking at my patients with a sepsis diagnosis and I want to understand more about an individual patient, let me just make sure. Here you go. You can click on the hyperlink of any beneficiary's name and you can see all of their claims. This is considered the claim detail view. You can isolate it to inpatient, ED, or PQI. You can sort by name or by any other detail that's provided here. And this is just giving you the full longitudinal view of what's going on in this patient if you want to be able to see outside of your walls and outside of your kind of your EHR to look at all of the claims for these patients. Okay, let's go back to our reports here. So that functionality of beneficiary detail and claim detail is accessible anywhere. I now want to focus on more the content of the reports. Next, I want to show you our emergency room utilization. Emergency room utilization report is highlighting the differences between emergent and non-emergent ED. So we use an NYU algorithm that is looking at the diagnosis for the diagnosis when patients present in the emergency room to determine if it is an emergent reason or a non-emergent reason. Effectively, non-emergent reasons would be situations where beneficiaries could have accessed their primary care physician for care, or if it was potentially an avoidable issue as opposed to a true emergent issue according to the clinical definition we use. So our top line here is showing the monthly trend of our NED rate in the blue, comparison group in orange. I will add that color is very meaningful in this reporting suite. Anytime you see orange, it's going to be your comparison group. Blue, there's different shades of blue, but it'll always be your population. And we can isolate if we're looking at ER count or NED rate. It's just going to change your y-axis. So here we're showing our historical utilization over time by fiscal year. We're also showing at our emergent and non-emergent ED rates by hospital. Distribution by ED and non-ED. Again, by primary diagnosis. And then this chart's allowing you to look at the beneficiaries that have higher utilization of ED, where beneficiaries who have more than one emergency room visit over the time period. By the plan all-cause readmission looks very similar and functions very similar. I want to pause for a second. Josh, can you hear me okay?
You're breaking up a little bit. I don't know if you
Oh,
potentially want to go
no.
camera off, if that might be better.
I'm going to go camera off. Thank you. Apologies for that. I want to make sure you can hear me clearly. Okay. Are we good now?
So far, so good.
All right. Please yell and we'll try to adjust if it changes. Plan all-cause readmission functions very similarly. It looks the same, it'll act the same, but we're focusing on all-cause readmission rates in here. So again, you can see your trends relative to the comparison group and then highlight the differences from a clinical and demographic perspective. Our PQI utilization report is focusing on just that. It's looking at the PQI algorithms to see the prevalence of those the prevalence of PQIs in your population. And when this loads, you'll be able to select the specific PQI of interest. So we do default to PQ90 for a composite rate. This is going to take just a second. This is a big report. Okay. At the top of your screen, you'll be able to filter on a specific PQI. We always usually go for PQI 90 or PQI 92 as a default, but you'll be able to isolate that to look at any one individually and then highlight the details about your PQI rates compared to your comparison. And again, by hospital diagnosis, kind of the frequent flyers, and then by demographic characteristics. All right, follow-up after inpatient discharge is slightly different than the prior. This is more looking at the utilization of not only having a hospitalization, but whether the member received timely follow-up after that. So follow-up from a primary care physician within 30 days of that hospitalization. And this might be a good opportunity for those interested to identify who's getting follow-up, who's not getting follow-up, and consider making a roster to make sure that you're looking at the population who's not and see if there's something that has to change in your process to get them timely follow-up. I'd say in the future. There is always a lag since this is administrative data, so just a more look at your process going forward. You have a slider, you can isolate time periods, but again, look at whether a member received follow-up or not from if they had a hospitalization in this, if they had a hospitalization at this hospital, whether they received follow-up or not. And that's what our differing blues are. You can see overall everyone who received follow-up or not. So if I see here that I have 216 inpatient admissions that did not receive timely follow-up, you'd be able to select this bar. Everything will update as it always does. And you'll see in just a second, it should pop up, a hyperlink to get you to the beneficiary details for everyone who did not receive follow-up.
Audrey,
Yeah.
question that we got was in the Medicaid beneficiary details, does it have the enrollment date, the Medicaid enrollment date for those beneficiaries in there?
It does not have the enrollment date. The closest is we have the redetermination dates in this report, but we do not have Medicaid enrollment. These will all be active Medicaid enrollees, though, because they're participating, they're assigned to you under Medicaid Pass. All right, let's keep going. The PMPM trend report is focusing on dollars, so everything else was based on utilization. PMPM is looking at the per member per month healthcare spending across all care settings to help you get a sense of where the concentration of healthcare spending is for your population. We break it down by each claim type. We also break it down by A and B. Since we're looking at a Medicaid population, it's effectively going to be your institutional care compared to your professional or your physician services. And again, with an overall, orange line indicating your comparison group. There's no drill throughs here. This is focusing more on just a distribution of where care is being provided and where the drivers of the healthcare spending is by provider. All right, health equity by demographics report is going to again take us higher, or take us outside of our individual utilization metrics and allow us to look across our metrics. This is designed to be able to look at disparities and equities across the population by demographic category, specifically looking at age, sex, race, ethnicity, county, region, and dual status. So you'll see on the top section here, you're able to isolate a utilization metric. I would strongly recommend you focus primarily on rated measures, so rates per thousand, if you're interested in looking at any sort of disparity across populations. So I'm focusing now on my inpatient admissions per thousand members. And all of the spaghetti is showing me my lines by each different age group. If I find that this is a little too messy for me to look at and I want to focus my population on only let's take a few out, only my members younger than 60 years old, you can go ahead and isolate that and it'll remove those lines so you have a more clear view and you'll be able to see your trends over time. You also have the opportunity to cross-tab the data against two metrics. So instead of just having age, if I also want to look at dual status, if you recall, I have about 300 members who also are dually eligible for Medicare and Medicaid. This just popped out a yes, no. So this is my non-dual, these are my duals, and I'm now looking at age and dual at the same time. So hopefully this is helpful for you just to not only have a quick shot, you could just click through quickly and see how your trends are changing, but also to highlight the disparities among any of these population segments. Towards the middle of the screen, where we have disparity index, and a disparity index is effectively a mathematical calculation that's saying what is the rate of each of these populations relative to a base. Since this is a multi-payer reporting suite with a lot of Medicare use, our base population for age is 61 to 70-year-olds. So you'll see that everything here is divided by that. So 100 admissions per thousand for my less than 18 over my 217 gives me a disparity index of 0.46. Any number less than 1 is more favorable than the base. Any number greater than 1 is higher utilization or generally less favorable than the base. So it helps you easily just look down without doing the math yourself and say that there's particular, the 71 to 80-year-olds have a higher rate of admissions per K than our base population. You can even look at it compared to any other population. And then we're just bringing in chronic conditions here. So we're looking at age across the top by chronic condition going down to look at the rates of the inpatient utilization per K. All right. I'm going to now quickly cover the maternal health utilization reports. There are 4 reports and 2 quality measures here. This will be, of course, specific to your maternal health population, which could be very impactful in the Medicaid PATH program. The first report is focusing on maternal demographics. So this is all about the mother. This is saying what is the distribution by age for mothers. For birthing mothers, I'm looking specifically at completed pregnancies. You do have the opportunity to look at ongoing pregnancies as well. So definitely keep an eye on that. We're looking at the age, we're looking at the chronic condition, and we're looking at the geographic distribution in that panel. You can also look at the delivery options. So after delivery, you're able to look at the delivery type. So this is separating the cesarean versus vaginal deliveries, the cost of those deliveries and the differential, looking at the gestational age, the birth status, and the delivery hospital. So definitely helpful to keep in mind if you are focusing on that aspect of care. And all of these have drill throughs to the patient details as well. Prenatal and postpartum dashboards are looking at the prevalence or the timeliness of prenatal and postpartum care. So this is following the guidelines that mothers or expecting mothers should receive prenatal care at set increments. And this is first showing the gestational age at the first prenatal visit. And it's looking at the distribution of services. At this point, these are all non-ED visits, but there are several other categories that might show up. If there's labs, if there's tests, if there's hospital admissions, it'll show up the distribution. And it'll also show what percent of the population is getting prenatal visits at these recommended bands. So this does follow clinical guidelines for recommended prenatal care. And I can see here what percent of my population is not receiving that prenatal care. There is a lag in this data, but this does present opportunity for follow-up if you see that members are not getting prenatal care. Definitely you can flag them, make a roster for them, get in contact with them, or otherwise find an intervention that is suitable for you. Okay. Postpartum is the same. It's just showing you whether they receive timely postpartum care within 8 weeks of delivery. All right, we're going to get to those last 2 quality measures under a separate dashboard. So looking now at redetermination report, this is a separate report that really functions very differently. This is looking at who in your panel is up for Medicaid redetermination, definitely a hot topic currently. And what this does is this shows you the next redetermination date for everybody in your panel. Sorry, this data is so very old in my demo site. So let me see. Let's see if anybody here shows up. This is effectively just going to say who is going to need a Medicaid redetermination within the next 30 days. This is a live counter. So when you come in tomorrow, this is saying it's 28 days to redetermination. When you log in tomorrow, it's going to say it's 27 days to redetermination. So hopefully this is giving you a heads up to make sure that you are in contact with the member and helping them do what they need to do in order to maintain their Medicaid coverage. Okay, So this next reporting suite prediction tool, I'm not going to cover on today's presentation. I hope you join me 2 weeks from today. We're going to cover prediction tools. We're going to have our colleagues at the Hilltop Institute to come and talk to you about those prediction tools. There is avoidable hospitalization, avoidable diabetes complications as well. And they will be talking through those details, how their model works, and I'll be demoing that report at that time. So just a little call out for that. Please join us in 2 weeks to hear more about that. So I want to spend the rest of the time on the quality measure dashboard. I do think we will have time for plenty of questions, so I'll go through this in maybe the next 5 minutes or so. Quality measure dashboard is a kind of separate, isolated suite in this reporting suite that is calling out these, I think, 14 different quality measures. These are not necessarily specific to Medicaid path. They are not specific to your, to AHEAD primary care programs. These are quality measures that that the state just found generally interesting and wanted to make sure that people had access to. So there's 3 types of measures. You have rate-based measures that are all focusing on a beneficiary and whether they have received care in the last year on any of these metrics. Did they receive the appropriate, or excuse me, do they have the appropriate asthma medication ratio? Do they have their HbA1c controlled or not? Have they been controlling their high blood pressure? It's a yes or no about a patient or about a member. Um, as opposed to rate-based events, which is looking at follow-up care following an event. So 30-day follow-up after emergency department for alcohol or other drug abuse, follow-up after hospitalization for mental illness, and the like. So this is focusing on an event and whether the appropriate follow-up or utilization happened. And then last, we have our count-based measures, which has no comparison group. These are just effective counts of services according to formal measures. So inpatient utilization measure, admission to institution from the community, those are all outlined there. So I want to cover for us today asthma medication ratio. All of these are active widgets, so go ahead and click on one and you'll be able to get more detail about that specific measure. Again, from this view here, you can just do a quick shot at how you're performing relative to a comparison group. All of the rate-based measures are, all the rate-based measure reports function the same way. So I'm just going to show you one and it is comparable for the rest. We're looking at asthma medication. You do have your description of that quality measure at the top. You also have an little I info button to give you more details if you want to understand more about these. All of these quality measures in this reporting suite are Medicaid core set measures. You can get the specifications and details online, but we give you just a quick snapshot so you understand what you're looking at. And again, these are all claim-based measures. We do get clinical data with our integration from CRISP, but these are not self-reported. It's only what's in the claim. So this measure is making sure that members have an asthma medication ratio greater than 0.5. We are looking at that rate. This happens to just be a small population for the measure I'm looking at. But by chronic condition, what percent of the population has their AMR in the appropriate range? It is also showing us an overall where I see I'm doing well, I'm doing far better than the state comparison. 81.3% of my population, for my eligible population for this measure, has their AMR greater than 0.5, compared to about 55% of Medicaid overall. Again, demo data just for illustrative purposes. But
Audrey,
yeah.
sorry. So we got a question about the A1C measure. I believe
Ah,
it's supposed to be an inverse measure, and it looks like
it
it's
is an inverse
not.
measure. All right, let's talk about that.
Okay.
Let's go there instead. Because it is an inverse measure. The data you see is directionally accurate for it being an inverse measure. This is not clinically representing what we know that this is not clinically representing what is going on in the state. We know that hemoglobin poor control is not 90% poor control. However, this is based on claims-based information. This is your opportunity to help improve the quality measurement across the state. The reason why this rate is so high or effectively so poor is because the HbA1c values are not getting coded in your claims. Not yours specifically, but really it's systemic across the whole state. So you will see, according to the HbA1c quality measure, if the HbA1c value is missing or is greater than 9, it is going to be indicated as poor control. So when you look at these results, Alma, you're totally right. It's scary. What do you mean I have poor control over 90%? A lot of that is driven by the missing values. So we do have this table here to isolate that of missing. Um, so like I said, it is not clinically reflective of your population, but it is reflective of the claims and the data that we have access to. So you do have an opportunity here to just toggle, and you can just exclude the beneficiaries that are missing, and this will give you a better clinical representation of your population. I think I would be remiss if I did not note that more appropriate coding of this clinical indicator would help improve your results. So please take that for what it is. If you're able to get the appropriate ICD-10 codes or CPT2 codes into the claims to reflect the HbA1c score, it'll improve the performance of these reports. But by removing this, you'll see my number drops considerably. I have a 3.7% poor control of HbA1c, and you can look at the distribution by chronic condition. So this is not consistent with the formal measure definition, but it does help you be more reflective of your clinical profile. Okay, that's my public health cat plus a little data hat all at once. And while we're here, this is showing my distribution by race, by ethnicity, by age, and by sex, and all of the quality measures have this distribution as well. All right, let's show one more. I want to do FUH, follow-up after hospitalization, 30-day follow-up after hospitalization for mental illness. Definitely an important quality measure. We want to make sure we're tracking. You'll see here that the presentation is a little bit different. You have a line chart over time that's showing you the hospitalization and whether it had follow-up or not. Helps you identify any seasonality or anything that you want to look at, across your 12 months. Also has your presentation of your overall results here. And then again, showing you the follow-up or lack of follow-up by these demographics. And per usual, you can click on anything, filter everything according to, I'm looking at major depressive disorder. And in a second, if it's cooperating, it should pop up a beneficiary detail here as well. Okay. I'm going to jump now to health equity by demographics. This is going to function exactly the same way as your health equity by demographics utilization report, but this is going to focus only on your quality measures. So this is a great way to just click through and see how does my performance differ by quality measure for the demographic characteristic I'm highlighting. So I'm showing everything by age here. I can just click through and see if there's any trends or anything I want to kind of highlight. Like I'm looking here, my 18 to 30-year-olds for CBP is looking pretty great. So you can do it by age. Again, you could do it by age, sex, race, ethnicity, all of that. Also pull out your separate chart and also isolate any populations that you want to focus on. And again, we get disparities and we get chronic condition distribution as well. Okay. That I think is all I wanted to cover with you today. So thank you for your patience. I know I went through this quite briefly, but I want to now reserve some time. We have 10 minutes to cover any questions. So Josh, I'm going to actually turn it to you. If there's any clarifications you'd like me to make or anything you addressed in the chat that I should just verbalize to make sure that everyone saw, I'm happy to do that now. Or if there's any questions you did not get a chance to ask, feel free to raise your hand and we can get to those as well.
Yeah, I think from the questions standpoint, um, Um, hmm. I think there's a question regarding like how to make sure the panel that they're viewing in the multi-payer reporting suite is the latest one they uploaded. And from my understanding, the best way to do that is by using the date panels through date. But I don't know if there's another solution that can be used for that.
Well, Josh, isn't it an override panel?
Yes, but say they update their panel with their new MCO assignment lists, like having an understanding of when that is in there.
Yeah.
Um,
So I think there's two ways to do it. You're going to have the date. It's not showing right here, but we're adding that of the last panel upload date is going to be displayed here. But when you do that download from the MCO assignment list and you then send it over to send, you have your master copy of everyone you should see. So doing just a quick comparison of if I know I uploaded 2,000 people because I have 2,000 members this quarter, my panel's only showing me 1,800, and that's what it was last year. It'll give you a quick indication that something's awry there. So that's a manual check that you can do, but we are looking to add a visual cue here just so you know the last time your panel's been updated.
thanks. Another item I want to emphasize to the group, since I saw a lot of questions, is about getting access to multi-payer. So there's a couple of steps. First, your organization needs to have a panel set up with CRISP. You need to have completed that first upload of that panel. And then typically a couple days after that, we are able then to credential on our side. But I think it's what's really helpful is if you let us know that you would like access to that panel in multi-payer because you've completed your upload. And I can put in, it should be report dash support at crisphelp.org. And they can handle your multi-payer credentialing needs. Any other questions anyone has? Or we have a few more minutes. Okay. Well, if not, we can give people back about 5 minutes of their time. Thanks, everyone.